Hello, this is Kim Jong-il. Today's topic is part 2 of upper second molar extraction. Many of this patient's teeth are in retained root state, and dental implants are placed in the teeth 16 and 26 areas. There is a bilateral posterior crossbite, but crowding is not severe. In this case, it is better to treat with non-extraction approach. Teeth 17, 25, 28, 37, and 45 are in retained root state, and teeth 16 and 26 areas are already restored with dental implants. Then what should be done with tooth 18? Should it be extracted and replaced with dental implant or pulled into the tooth 17 area? Because of the maxillary sinus, there is a limitation to pulling tooth 18 and completely closing space. How should the upper left quadrant be treated? Teeth 25 and 28 should be extracted, space in the tooth 25 area can be closed, and tooth 27 can be uprighted. How about the lower left quadrant? Tooth 38 is in a good state, but tooth 37 has to be extracted. Tooth 38 can be extracted and replaced with a dental implant, or the extraction space in tooth 37 area can be closed. It would be more efficient to close space if there is anterior crowding. What should be done with tooth 45? It would be ideal to close the space by bodily movement, but there is a limitation. Still, it would be much better to close the space than opening. When closing the space, tooth 48 should not be extracted because tooth 17 will lose antagonist tooth to occlude, and as a result will be extruded and have to be extracted. Therefore, despite the limited treatment response, orthodontic treatment can be carried out with appliances attached to the third molars. This is a U44L55 extraction treatment case. Tooth 26 is treated well endodontically, but tooth 37 is only partially treated. According to the Department of Restorative Dentistry, tooth 26 can be saved, but tooth 37 has a poor prognosis. So how should this patient be treated? Tooth 37 has to be extracted, and tooth 38 can be either extracted and replaced with a dental implant or pulled to close the extraction space. There are many cases with pathologic condition of the second molars, such as severe decay or root resorption, and these teeth should first be extracted. If tooth 37 is extracted, tooth 38 will obviously be impacted, but it can be uprighted and moved forward by attaching an appliance. 1. When there is a posterior discrepancy in the upper arch, extraction of the upper second molar is recommended. In this case, the upper third molar can be left unbonded, but there are many cases that require bonding of the upper third molar. If the upper second molar is in a poor condition, it can be extracted and the upper third molar can be aligned by orthodontic treatment. In this patient, teeth 17, 37, and 47 are partially impacted, and tooth 17 is somewhat more impacted than the other two. Can the third molars extracted in this state? It is not easy. In particular, in Korea, the eligibility of national health insurance for the extraction of third molar is age-dependent, so this patient may not be covered. Therefore, in this case, tooth 18 can be extracted and tooth 17 be pulled, or tooth 17 can be extracted. However, because it is difficult to extract the third molars, the second molars should first be uprighted and aligned into the arch. 2. If there is a scissors bite on the second molar, how is it treated? In case of scissors bite, the upper second molar is extruded and buccally tipped, and the lower second molar is extruded as well and lingually inclined. So the upper second molar should first be intruded and tipped palatally into the arch, and the lower second molar should be aligned into a proper position. In order to move the upper second molar, mini screws or TPA with hook can be used. However, if extraction of the upper second molar is indicated and the upper third molar is in a good condition, the extraction of upper second molar can simultaneously resolve anterior crowding and scissors bite on the upper second molar. In this patient, there is a scissors bite on teeth 17 and 27. The lips are slightly protrusive, but the profile is acceptable. The roots of teeth 18 and 28 have already began to develop, but they are in good conditions. Is it better to extract the upper third molars and intrude the upper second molars, or extract the upper second molars? It is better to extract the upper second molars. In the mandible, the third molars can be extracted. After resolving anterior discrepancies in the upper and lower arches, the eruption of upper third molars can be expected. This patient also shows severe scissors bite on teeth 17 and 27. Likewise, the upper second molars and lower third molars can be extracted to make the orthodontic treatment easier and maintain the current profile. Of course, the upper third molars can be extracted and the upper second molars be pulled into the arch, but it is difficult. This adult patient has a severe scissors bite on teeth 17 and 27. Tooth 18 is erupted, and tooth 28 is impacted. Tooth 27 is decayed. The upper third molars can be extracted, but in order to make the orthodontic treatment easier, the upper second molars and lower third molars can be extracted. Although teeth 18 and 28 need to be bonded and moved into proper positions, the treatment result will be much better. These are the post-treatment photos. Teeth 18 and 28 were bonded and moved into the arch. 3. There are cases where the upper second molar is extruded. Unilateral extrusion of the upper second molar results in midline deviation, and bilateral extrusion results in class 3 malocclusion. The extruded upper second molars should be intruded so that the lower dentition can be moved posteriorly. However, if extraction of the upper second molar is indicated and the upper third molar is in a good condition, the upper second molar can be extracted. In this patient, the extruded tooth 17 contacts on the distal surface of tooth 47 and causes the mandible to deviate to the left. In this case, teeth 17 and 27 can be extracted in order to treat class 3 malocclusion. This patient has an acceptable profile, but the lower midline is shifted to the left. Similar to the previous case, the extruded tooth 17 contacts on the distal surface of tooth 47 and causes the mandible to deviate to the left. The canine key is class 1 on the left, but full class 3 on the right. Should tooth 17 be extracted or not? Tooth 18 is not in a good condition as it is too calcified and small. In this case, tooth 17 should be intruded even if it is difficult. 4. In class 2 malocclusion, there can be an anterior crowding and normal overjet, or no crowding but large overjet. In this case, if the upper third molar is in a good condition, the upper second molar can be extracted so that the upper dentition can be moved distally. In this patient, there is a severe crowding on the left side but only a minor crowding in the lower arch. Then, if the profile is acceptable, the condition of upper third molar should be evaluated. Size and calcification are okay, so tooth 27 can be extracted. Of course, tooth 17 can be extracted as well, but if there is no problem with tooth 17, it is better than tooth 18. After the extraction of tooth 27, tooth 28 can erupt well, and tooth 26 can be moved distally into the extraction space. In this patient, the upper incisors are lingually inclined, and the canine and molar keys are half class 2. There is a minor crowding in the lower arch. Then the condition of upper third molar should be assessed. Because tooth 18 is in a good condition, tooth 17 can be extracted, and the upper dentition can be moved distally to the extraction space. The rest of the third molars can be extracted later. To sum up, in case of class 2 malocclusion, only upper second molars can be extracted as long as the profile is acceptable. Likewise, in this patient, the pre-treatment profile is acceptable, but there is a unilateral crowding on tooth 13. If crowding were bilateral, only upper premolar extraction can be considered. But since crowding is unilateral, there is a high chance of arch distortion if only upper premolars are extracted. Therefore, tooth 17 is extracted, the upper right dentition is moved distally, and tooth 18 can erupt well. In mio-orthodontics, much emphasis is put on whether the canine key is half class 2 or full class 2. Mio is very effective for half class 2 but not in full class 2. Therefore, it is important to change the full class 2 canine key into half class 2 during alignment before inserting mio. In class 3 malocclusion, there may be crowding or not, which is better for non-extraction treatment. It is better if there is a crowding because the upper incisors can be moved anteriorly during alignment. On the other hand, if there is no crowding, it is difficult to move the upper incisors forward during alignment. In case of class 3 malocclusion with upper anterior crowding, the upper incisors are labially inclined during alignment as well as finishing. Then is it better to extract the upper third molar or second molar? It is better to extract the upper second molar. However, the indications must be met for upper second molar extraction. The profile should be acceptable, there should be no or slight lower anterior crowding, and the upper third molar should be in a good condition. By extracting the upper second molar, labioversion of the upper incisors can be minimized during alignment by moving the upper molars distally. This patient has a severe class 3 malocclusion with protrusive chin and severe upper anterior crowding. Of course, surgery is a good option, but it is difficult for the patients to decide on surgery for various reasons. Therefore, this patient chose to proceed with orthodontic treatment only. During alignment, despite the linguoversion of upper incisors, it is not good to labially incline them too much. So the upper second molars and lower third molars were extracted. As a result of the treatment, the upper lip is slightly protruded. The upper third molars erupted well into the dentition. This patient has a class 3 malocclusion with posterior crossbite. The profile is acceptable. Now it should be decided whether to treat with non-extraction approach or extraction of the upper second molars. Because the upper third molars are in good conditions, the upper second molars were extracted. Eruption of the upper third molars can be expected, and the lower third molars should later be extracted. 5. So the fifth case of upper second molar extraction is non-surgical treatment of class 3 malocclusion with upper anterior crowding. Extraction of the upper second molar can be performed in both class 2 and 3 malocclusions. There are many cases of class 2 and 3 malocclusions in which posterior vertical dimension is deficient. In class 2 malocclusion, the forward movement of mandible is often limited by the upper second molar. In this case, by upper second molar extraction, the mandible can move forward and the upper dentition can move posteriorly at the same time. In Class 3 malocclusion with deficient PVD, the backward movement of mandible is limited by the upper second molar, and the face becomes longer. In this case, by extracting the upper second molar, the lower dentition can move posteriorly. There are many cases of open bite due to wedging effect, in which the mesial angulation of teeth results in occlusal contact only in the molars. In this case, is it better to extract the upper third molars or the second molars? If the indications are met for the upper second molar extraction, it can make the treatment easier by moving the upper dentition posteriorly and extruding the upper anterior teeth. This patient was already orthodontically treated, but relapse of anterior open bite occurred because posterior discrepancy was not resolved. The upper third molars can be extracted, but it is difficult to upright the molars. Therefore, the upper second molars and lower third molars were extracted to upright the entire dentition and resolve wedging effect. In this way, anterior open bite can easily be treated. 6. The sixth case is extraction of the upper second molars to eliminate wedging effect. In case of full Class 3 malocclusion, it is appropriate to treat with surgery because it is severe. However, the patient may still want non-surgical orthodontic treatment. In this case, I recommend the extraction of upper and lower second molars. All 4 of the third molars have to be in good conditions, and the entire lower dentition can be moved posteriorly. The condition of upper third molar may not be good, and there is a limit to the treatment with only lower third molar extraction in case of full Class 3 malocclusion. Other options, such as only lower second premolar extraction or only lower second molar extraction, can be considered. If only the lower second molars are extracted, the lower third molars must not be extracted. This patient has a full Class 3 malocclusion without crowding in both the upper and lower arches. Teeth 17 and 47 were extracted, and eruption of teeth 18 and 48 can be expected. 7th case is lower second molar extraction in case of full Class 3 canine key. The lower third molars should be in very good conditions, and non-surgical orthodontic treatment should not be carried out if the lower third molars are not in good conditions. To sum up, these are the indications of upper second molar extraction. The premise is that the upper third molar is in a good condition, size, shape, and calcification. The angulation and position can be adjusted by attaching an appliance after eruption. 1. Pathologic condition on the upper second molar. Severe decay, root resorption. 2. Scissors bite on the upper second molar. 3. Extrusion of the upper second molar. 4. Class 2. Malocclusion without upper anterior crowding. 5. Class 3. Malocclusion with upper anterior crowding. 6. Elimination of wedging effects. 7. Lower second molar extraction in case of full Class 3 canine key. Thank you for watching.